Game over. It is game over.
Game over, cancer.
I'm Val Solomon, Director of Program Impact at Cannonball Kids Cancer Foundation.
And I'm Dana Nichols, Executive Director of CKC.
Game Over, Cancer, a podcast dedicated to exploring conversations about pediatric cancer research, solutions, and inspiring family stories.
We're a nonprofit dedicated to creating innovative treatment options for kids fighting cancer and educating for change.
By creating a space for these conversations, we empower the community to take action and provide tangible hope.
Game over, cancer. Screw you, cancer. We're so excited about today's episode with Dr. Stieglitz.
Yes.
He's one of our favorites. And I think we love when we really form a long-term relationship with a researcher because we get to see how much progress they made. And that always speaks to what is success.
Yeah. It was wonderful to be able to chat with him at this point after, investing a couple different times. We get into not only what does success look like, but like our relationship to when do we want these results and how many steps it actually takes to get a clinical trial and create options. And, I think I come away thinking, wow, we really are on step 900 is when we meet the researcher. And so this was a great opportunity to delve a little bit more into how does the only JMML clinical trial in the world get started.
Yes, so enjoy the episode.
Our guest today is Associate Professor of Pediatrics at UCSF School of Medicine. He's a pediatric hematologist-oncologist who cares for children with difficult-to-treat leukemias. And his research in his laboratory focuses on JMML, which is often difficult to diagnose and treat. His research has found that the course of JMML varies among patients and that DNA profiling can predict which patients will benefit from certain new treatments. He is also a Scrabble enthusiast and recipient of 2 CKC clinical trial grants, one in 2021 and most recently in 2025, for phases 1 and 2 of his research. Please welcome Dr. Elliot Stieglitz.
Hello.
Thank you for being here.
I didn't know we were playing
pleasure.
Scrabble today.
I know.
Love that. We know that for our audience, we have talked so much about your work through the years because for us, being able to partner and come back around a second time and partner is like kind of the dream of why CKC is here. And I putting words in your mouth, but to say that like the dream is that you work on your trial and you go to the next phase, and we're learning from it. So we thought maybe for the audience, we would baseline a little bit about leukemia. So I have like one more preamble sentence and then I'm going to throw it to you, an actual expert. But one of the bits of education that we find really important, but also sometimes hard about leukemia is some leukemia has really great stats. And we talk about an 80% success rate and this and that, and can kind of morph into pediatric cancer has that success rate or those types of things. But when we're talking about JMML and specifically what you are working on, it is very, very difficult to treat cancer. It is very low success odds for treatment. So we thought we'd just start there a bit about like the overall landscape of where you're working from.
Absolutely. So leukemia is a blood cancer. In children in the United States, there are about 4,000 cases per year. Approximately 3,000 of those are the most common type of leukemia, which is called acute lymphoblastic leukemia, ALL. And like you mentioned, when a child is diagnosed with ALL, we're having a conversation with the parents and we're talking about what is the minimal amount of therapy that we can deliver and still have a cure rate of 80, 90, sometimes even closer to 100%. The next most common type of leukemia is AML, acute myeloid leukemia. That is a more difficult type of leukemia, still curable. It just requires more intensive chemotherapy, and in about half of cases requires a stem cell transplant. Or a bone marrow transplant. Those are synonymous. And so obviously the intensity and the side effects are escalated, but it is still curable. The next most common type of leukemia is what we study, which is called juvenile myelomonocytic leukemia, which is a mouthful. So we say JMML. And that affects about 50 to 100 patients per year. And historically, this was very challenging to get into remission. Every patient required a stem cell transplant, and only about 50% of patients were long-term survivors.
Wow. That's really difficult to hear and think about and know how rare something is. But for those 50 to 100 families, like to know what they're being plunged into is really, really difficult.
Mm-hmm. And so I think I probably know the answer. And I guess if anybody's been listening to our podcast, they could probably predict. But then how did you end up studying JMML? And why? How does that become the focus of your research career?
When I was a resident in New York City, I was taking care of a patient who was suspected of having this diagnosis of JMML. And I remember all the other doctors almost all at once said, okay, call the doctors at UCSF. They specialize in JMML. They're going to help you make this diagnosis. And so that's what we did. We participated in a tissue bank study where a parent can donate a sample of blood or bone marrow to a registry so that researchers can learn more about the disease and help potentially that patient, but also patients in the future. And going through this process, the doctors were able to make a diagnosis using a molecular technique. And that entire experience just changed everything for me. I immediately knew that that's the sort of translational work that I wanted to be a part of. I did not have a research background at the time. And so when I applied for fellowship, I applied to programs in my home state of New York and then also in California, in San Francisco. And I ended up coming out here really specifically to learn how to become a physician scientist. And yeah, that's the origin story. And it's been an amazing journey ever since.
That's incredible. I think too, we see you as such a leader in this field. It's fascinating to hear like, okay, well, I needed to find the institution, the partner where I could be that wanted to invest in the work. Not just, I had this idea. It takes so much to really invest in research in a way that moves the needle forward.
Mm-hmm. Yeah. And I think the other thing that comes up for me too is that we know you now that we've, known you for a few years. You were funded first in 2021. Now we've come back again. And so we've interacted with you enough from the funding perspective to know you as a very collaborative individual, not just, in how you treat patients and, help and advise the treatment of kids with JMML across the country. But also, I think there is something there to the fact that you found an institutional setting that allows you to do that, not just with the way you advise treatments, but also within your own research. So can you talk a little bit about the impact of collaboration and what that's how that's impacted your research? What is it about where you are now that makes what you do possible? I think is also interesting. You could talk about that.
Val, first, thank you. That's very generous. When I meet with fellows or trainees, I often start by saying, there are a few keys to success. No, number one is luck, and let's just put that out there. Number two is picking a good mentor, which very fortunate. And that was really the main attraction to come out to San Francisco, was to train with my mentor, Dr. Mignon Lo, who's no longer here. She's in Seattle, but still plays an outsized role in my personal and professional life. And then I think collaborations is a big key. So I mentioned UCSF has been a leader in the field of something called RAS biology in pediatric leukemia for many decades. And a lot of the seminal discoveries in JMML happened here. So I did not start in a vacuum. I started with many, many individuals who came before me and essentially created this field. And using that as a foundation, I've been really fortunate to have some amazing projects, amazing collaborations, and we've changed how we deal with this disease at this point. We've changed how we diagnose it. We've changed how we risk stratify patients to receive different intensities of therapy. And we've also changed what drugs are considered active in this disease through clinical trials. So it's really been an amazing journey. And I can say none of this would have been possible in a vacuum. And this was the right spot for me. And I think every trainee, when they start, needs to think about the environment from a holistic perspective.
Yeah, absolutely.
That's so true. Every work environment, right?
Yeah. Can you talk a little to some of the changes or progress that's been made in how you're treating and assessing treatment paths for JMML?
Absolutely. So when we started, I mentioned it was very difficult to make a diagnosis, and you had to reach out to somebody in another institution.
Mm-hmm.
And my first project in the laboratory during my fellowship was to read the letters of DNA from 100 patients that were diagnosed with JMML. And at the time when I started around 2011, the diagnosis was actually something that we referred to as diagnosis of exclusion, which means that a child was suspected of having leukemia. It wasn't the common type of ALL or even AML. And almost by exclusion, if they had a leukemia that looked what we call myeloid in nature, and they had a relatively big spleen, they would be called JMML. But there was nothing specific that clinched the diagnosis. And so you can imagine that makes it really challenging. And patients would often go weeks, months, even longer just to make a diagnosis. And so when we read the letters of DNA from these 100 patients, we saw that every single patient had a mutation in a family of genes called RAS, RAS. And RAS regulates whether a cell grows or dies. And when there's a mutation or a change in the DNA in one of those genes, the signal is essentially always on, and the cell is growing, not growing. And that is the hallmark of cancer, when a cell grows more than it should. And so with this identification that every single patient has a mutation in the RAS family, we are no longer a diagnosis of exclusion. We can look inside of the DNA and make this identification of a mutation. And if there's less than a certain percentage of leukemia cells with this mutation, we can now make the diagnosis. And we offer a test at our hospital in a clinical laboratory, not a research laboratory. And so any physician around the world can send us a sample, and 10 to 14 days later, we will send them a result, a clinical result that says this is the mutation, and then the doctor can make the diagnosis.
Wow. I mean, I know that at the end of the day, hearing that your kid has cancer is not something anybody wants to go through. But imagining that, you get a diagnosis that we think it's cancer, and it's clearly cancer, but we think it's this kind, but we're really not sure, has got to be one of the toughest things that a parent has to hear. And probably as a clinician, one of the toughest things you have to tell a parent of a child that you're treating. And so I think I see a little bit, a glimpse of how that was such a motivator for you to kind of like jump into the system of trying to fix that. And what is it like when you get results back and you're like, wow, it's every single child, this is really something? Like as a person who gets excited about smaller things, that must have been like really huge and really cool. What was it like to know you were onto something there?
Yeah, well, first of all, I agree. In a time of chaos, which is the diagnosis of leukemia in a young child, this disease typically affects infants and toddlers, the last thing that a family needs is uncertainty.
Yeah.
And even though this is not something that a family wants to hear. In the context of knowing that there is a type of leukemia, you at least want to know what you're dealing with so that you can get started on the journey, you can get started on the treatment. And so I do agree that that's really helpful. The process of studying those 100 patients was incredible and something that I think back to all the time. There were a few aha moments during that exploration that will stay with me forever. One of them was identifying new mutations in the RAS pathway that had not been seen in any type of blood cancer previously. Some of the mutations were seen in other blood cancers, but not JMML. And each time it was like studying a puzzle and putting the pieces together. And yeah, there are a few distinct moments, just, finding one letter that changed out of 3 billion in a cell, and just knowing in the moment, oh my, this is definitely what caused this child's cancer, was wild. One, from a diagnostic perspective, and then two, now we have treatments for some of these mutations that are more targeted, not just a stem cell transplant, which is using a hammer for any small problem. So yeah, there were a few moments that really stood out. And another thing was, by reading every letter of DNA, we also realized that a few of the patients in our cohort didn't actually have JMML. And because this used to be a diagnosis of exclusion, there were patients that snuck in under that umbrella term that didn't really have it. And uncovering that was also an aha moment, but a little bit more emotionally filled, in the sense that, there was diagnostic ambiguity there. So that was a little challenging.
Yeah.
And so now, I mean, that was, like you said, 2011 was when you were working on that. And so, we're, fast forward not very long in the scheme of things. And now you have developed a test to be able to risk stratify those patients to make sure that only the kids that need a stem cell transplant are the ones that are receiving them. And so things like that, I know, are so important to us and our mission. And it's exactly the type of research that our supporters are looking to fund. So can you talk to the audience a little bit about what that diagnostic has done, and how do you, and that risk stratification, and why that's so important?
So one thing that I want to start out by saying is that project started in 2011, 2012, wasn't published till mid 2015. And that's considered a short duration of time for a project like this.
Yeah.
So, sometimes it's important to remember the scale and the scope of these projects. In particular, when it comes to funding, often you're not seeing a return on investment in the first months or even first years after the project starts. But, important projects often take time. So to publish this finding that every single patient with JMML has a RAS mutation in 2015. As part of that project, we also started to look at something called epigenetics. So genetics is when you read the letters of DNA inside of the cells. Epigenetics means that we're looking at molecules on top of the letters of DNA. So if you read the letters of DNA, they can be the same between two individuals. But if you were to look at some of the molecules, in particular something called a methyl group, which is a combination of carbons and hydrogens, you can actually find differences in the molecules on top of the DNA. So the DNA looks the same. If you're looking at the A's and C's, it's the same. But if you look on top, they can differ dramatically. And what we realized through a separate but related project, the methylation patterns, when you look across the entire genome or all of the letters of DNA inside of a cell, there were patterns of methylation that predicted who needed a stem cell transplant and who did not. And once again, this was a long-term project that started in 2014. We published our work in the United States in 2017. And at the same time, there were two groups in Japan and in Europe, mostly in Germany, that published very similar results. And one of the things about being in this community of JMML research is that we collaborate very closely. I think oftentimes there can be competition in science, but we're such a close community that we've actually collaborated very nicely. And so what we decided to do is we were going to pool all of the data from 3 continents, from North America, from Europe, and from Asia. And we worked together to make a definition of the different methylation signatures. And we published that result in 2021. And that led to the development of a clinical test that we offer as part of our current clinical trial that looks at methylation. And that's the only methylation test in any type of leukemia in children or adults. So it's really the first of its kind, and we're really proud we were able to publish it, but more importantly, offer a test to patients.
Yeah, it's incredible. And I think when like everything you're talking about to me just speaks so much to the long game that you have to be in this field. And like even that feels like, okay, well, we're just at the beginning now. So what's next? And that is where you are, right? So I just want to let you keep talking about what's next, because we're at 2021. But as Val said, that's kind of where CKC comes into, around that time of being able to seek out exactly that, like not just first of its kind, the only of its kind, is really, really incredible. So what do you do once you have that information, and how does it change the path of treatment for kids going forward?
So Dana, we see eye to eye on this, and that's why we've connected through this. So we have this signature now that helps predict which patients are most likely to successfully avoid a stem cell transplant. So the question is, what are we going to give those kids post stem cell transplant? It's unlikely that they need nothing, although it's possible some patients might. And so that's where we wanted to investigate some medications that have been used in adults but are still not approved for any type of pediatric leukemia. And so now that we knew every single patient that has JMML has a mutation in this family of genes called RAS, we wanted to try and block RAS, right? If every patient has increased levels of RAS, maybe we could try and block that to slow the cells from growing. And there hadn't been a drug that could actually block RAS directly, but there was something called a MEK inhibitor, which is right below where RAS sits in a cell signaling pathway. And if you block MEK, you can block a lot of the output from RAS. And so we borrowed this drug from the adult community. The drug's called trametinib, and we ran a phase 2 clinical trial for children that had not responded to traditional chemotherapy. So many of these kids had received chemo or a stem cell transplant, and their JMML came back.
Wow.
And so we gave those children an oral medication called trametinib, which is a MEK inhibitor, and we saw really surprising responses. 7 out of the 10 children benefited from this drug. 5 had what we call objective clinical responses, where it was just very clear to the naked eye that these children were much better after starting the drug. And so now we know that drug has activity. And so what we're doing right now is we're running a clinical trial that incorporates all the things that we've talked about. So in order to get on the clinical trial, you have to have a RAS mutation, and the sample comes from anywhere in the country to UCSF. We do the mutation testing, and we look and we make sure that a patient has a mutation so that they're eligible for the trial. Then we also do the methylation testing in collaboration with the National Institute of Health in Maryland. And that tells us whether the patient is likely to be able to avoid a transplant or not. And then we're also treating the patients with trametinib to try and prevent relapse in the first place in the newly diagnosed setting. And we also give it in combination with standard of care therapy. So that's the overarching treatment schema for our current clinical trial. And I have to say, Cannonball was the first organization that stepped up to the plate and said, even though this is kind of early in 2021, we believe that this is a good idea. We're going to give you initial funding to try and get the $3-4 million that's required to run a large clinical trial like this across 25 centers in the United States. And that's exactly what Cannonball did. They gave us the money, and we went and applied to the federal government, to the National Institute of Health, and we got the funding to run this clinical trial. So the trial doesn't happen without Cannonball's initial philanthropic donation in the form of a grant.
Well, thank you for saying that. But I mean, the trial doesn't happen unless you devote your whole life to this. So the least we can do is say, wow, someone is really exploring the unexplored. Someone is looking at every single way to holistically treat this type of cancer and make life better for these kids. That's why we're here. So we love it. It's our favorite thing to do, to find a partner that it makes sense all the way around. So it's, in that sense, just a mutual love fest and respect for sure. I think there's so many things that strike me about what you do, but we've talked a couple times about collaboration, and I think it's really important to I want to, if we can do one more second there, because I think one of the things we've talked about is how much time you spend now on the other side of what you said was your starting point, which was you had a patient that needed to be diagnosed and you wound up calling UCSF. But still to this day, most people would be calling now, not only UCSF, but you, to talk through this potential diagnosis. And I think to be at an institution that greenlights a lot of your time for that understands how important that is really huge. And maybe we could just talk about that as your experience for a little bit.
Speaking with families is the most important part of my job, in the sense that this is still a rare disease. When it affects a family, that's all they're thinking about in the entire world, but it's still rare. And any given individual doctor may see a patient once every few years, maybe even less frequent. And I think it's important that there be a resource for families to speak with someone that sees this all the time. And I know on the opposite end of that very frequently, where I encounter a rare diagnosis in one of my patients, and I want to reach out to an expert wherever they are to be a sounding board. And I know how valuable that is for myself when I'm in that position. And I hope I'm able to offer that for patients and for doctors in reverse. And the work that I get to do in that sense really straddles between research and clinical care. So when I speak with these families, I am also offering participation in studies, whether it's a tissue bank study like the one that I mentioned from 2011 to run here, or whether it's clinical trials where patients are being offered the opportunity to receive newer medications. That is really important. And the way that we've moved from 2011 with the diagnostic test, the risk stratification test, the treatment options, that is all based on research that we've done with samples from patients. So it's critical that we keep this virtuous cycle going forward of receiving samples in the lab analyzing them, studying them, learning from them. These patients want to teach us. We have to learn from them, and then forward into the next iteration. So when I meet with these families, it's research. It's also clinical care. We're making recommendations about diagnosis and treatment, and it really spans a spectrum. It's not very clearly delineated, and I really like living in that space. And I'll just refer to that again as this translational space between something at the bench in the lab and something in the clinic. Patient, we're right in the middle.
Yeah, absolutely.
Well, I think hopefully everyone will be able to understand now why you are a CKC-funded researcher.
Mm-hmm.
You're absolutely a wonderful example of seed funding to full NIH funding, phase 1 to phase 2 success, creating options where there are none, and just a very caring doctor who wants to do the best that he can every day for the families that he is helping. So we really appreciate your time on the podcast today. And, of course, everything that you do for these kids who are fighting and for their families. And, you're always there with a wonderful quote about our impact on your research. So we really appreciate everything.
Absolutely. Well, Dr. Stieglitz is the reason we exist, and the reason we are continuing to invest in innovative research so that we can make life easier for the children fighting, and in this case, their families and all that they're going through. If you want to support research like Dr. Stieglitz's, you can make a gift on our website at cannonballkidscancer.org.
That's right. And we want to thank you for listening to Game Over Cancer. And we encourage you to leave a review because that helps us reach more listeners and educate for change.
Absolutely. Thanks for tuning in. We appreciate you joining us and making a commitment to be part of our fight. I'm Dana Nichols.
I'm Val Solomon.
And until next time, we'll CKC
See you later. Join us as we transform fear into courage and turn adversity into opportunities for change.
If you want to be involved in the conversations that create change in the world of pediatric cancer, take a moment, share, like, and subscribe.